right, so good morning, everyone. I'm Brittany Minnick. I'm the area director for Bristol Hospice.
I'm Erica Fisher. I'm the clinical supervisor at Bristol.
Today, we're just really going to introduce the hospice philosophy and kind of what we're doing in the home for you guys. So as we move forward and start caring for more residents in the St. Charles County, we can rely on you guys to help support our team and vice versa to help eliminate those frequent trips that you're making to some families and bringing them back and forth to the hospital. Our goal is to minimize that as best we can and for you guys to get to know us and how we can operate together. The purpose today, and sorry if I'm not talking too loud, so today we're going to talk a little bit more about the philosophy of care, talk a little bit more about the hospice benefit in general, who's going to benefit from this layer of care. So we're going to break down some different disease progressions and how to identify a hospice patient when eligible. Who provides this care and what does the IDT team members do in their role in the home? The service in which hospice provides, there's 4 different levels of hospice care that we'll dive deeper into, as well as what makes us a little bit different at the end. Each hospice company has to follow the same regulations. We all have to bill Medicare. We all have to follow what they say, but also each company has the opportunity to exceed those standard expectations. So what is hospice care? Yes, hospice care is end-of-life care. It is all about the journey leading up to that death. So end-of-life care is very hard to determine when somebody is going to pass. Yes, you have that definition that usually hospice is a diagnosis of 6 months or less. But that's also if that disease takes its normal course. When we're working with dementia and Alzheimer's and memory loss, that disease progression is very different in everybody. Some little things such as a fall can make a huge difference and make that disease progress a lot quicker. So we're going to talk a little bit about that, but also with Alzheimer's, when it progresses without those intermittent falls, we could care for that patient for a couple months or even a couple years. If they're showing a decline, we're going to continue to care for them. Hospice care is more so, I'm not a clinician, so I can talk more about the companion side of hospice. It's really there for the patient and for the family. So you have those emotional support individuals, cognition support, spiritual support, social support. It's really about the safety and security of not being alone through this end-of-life care. And as we're progressing in that disease, we're giving education to that family on what to expect if that disease takes its normal course. And we'll talk a little bit more about that moving forward. Okay, so the primary goals of hospice care. So we are there to provide the patient with peace, comfort, and dignity. We're there to manage symptoms and control pain. Erica's going to go more into detail about what those symptoms are. It can be anything from anxiety to pacing to frustration, anything really stress related. We want to honor the patient wishes, including any religious, spiritual, or cultural beliefs. Also, our goal is to keep that patient in the home wherever they call home. When hospice steps in, a lot of people think that you can't do this in a home setting. It's absolutely done, and it can be done well with the right education and the right resources in that home. And we're there to provide support to the caregivers in the family unit. Okay, so triggers for the hospice conversation. The next slide starts going to go more into the clinical of what you're seeing in the home. But if you're also talking with the family, they're expressing their concerns and their worries and their frustrations of going back and forth to the hospital, some conversations we need to have is there a change in their condition? Which means, do we have a change in their goals of care? Do we need to develop a plan of care, talk about their wishes? Increasing episodes of acute care, such as high-risk hospitalizations, increase in falls, increase of change in medications, or cognition decline. Progressive weight loss and opportunistic infections.
So we're just going to go over some criteria for hospice care. So the criteria to qualify for hospice is that you have to have a life expectancy of 6 months or less if your disease process runs its normal course. That does not mean that we have people on for only 6 months. We've had people on for years, but as long as they continue to show that decline over time, we can continue to qualify them. The desire for comfort care rather than curative care. So somebody wanting to be in the home and be with their family and their loved ones instead of going back and forth to the hospital for treatment. You know, somebody that has cancer and wants to stop chemo or radiation, or somebody that's got end-stage renal disease and they want to stop dialysis. We can help them be comfortable at home and not have to continue to go to those treatments. And like Brittany said, the home can be variable. It could be a facility, a skilled nursing facility, it could be an assisted living. We have people in independent living at the home setting. So it's really wherever that person calls home. They have to certify as terminally ill by 2 physicians. Usually it's, you know, if they're at a facility, it can be the facility's physician and our medical director, as long as it's 2 physicians that are saying that that person is terminally ill. They must continue to meet criteria at specified intervals. We call them benefit periods. So the first 2 benefit periods are 90-day periods. So, you know, we have them on for 90 days. We reassess to see if they still qualify, and then we reassess again after 90 days. And every period thereafter is 60 days. And at that point, we have our physician go out and do a face-to-face visit with those patients. And, you know, they have to say that they qualify for hospice services. Then the patient or POA must sign informed consent forms. They have to elect the Medicare hospice benefit. Any person older than 65 enrolled in Medicare can have the hospice benefit at no cost. And then most health plans outside of Medicare also offer a hospice benefit as well. We have a couple screening tools that we use, definitely more than the ones listed here and the ones that you guys have. But if you guys want to check out your handouts, the first one I'll talk about is this admission indicators for hospice. So this one is one that we hand out to a lot of our referral sources. You know, it helps them to check off these boxes and see, does somebody qualify for hospice? And they're not going to know 100%, but this gives them an idea, and it kind of triggers them to say, hey, maybe we should call Bristol and see if, you know, their nurses can come out and do an evaluation. And we're always happy to do so. Anytime you guys have a patient that you're like, this person may need hospice, we are happy to come out and evaluate time and time again. Doesn't matter how many times, we're happy to do it. So this screening tool is really nice. It kind of gives you an idea of the things that we're looking for. So it has the diagnoses that we use most often, COPD, CHF, ischemic heart disease, Alzheimer's, dementia, ALS, Parkinson's, MS, all of those we can use, CVAs, end-stage renal, all of that. If somebody's had a progressive weight loss, you know, over the past, usually we look at a 10% weight loss in the past 6 months, you know, or have they lost 20 pounds in the last month because they just stopped eating and they have no desire to anymore. That triggers us to say that person probably needs hospice. If they're having shortness of breath at rest or with activity, chest pain that's unresolved with any medication, those things trigger us as well to say maybe this person has a condition that would qualify them for hospice. If they're using O2 when they weren't usually, if they were going out and getting their groceries 6 months ago, driving their car, and now they're, you know, chair bound, they really need help, they're almost bed bound, that's going to qualify them for hospice. So it's little things too. It's somebody that's maybe somebody that has Alzheimer's that's able to talk to you and speak more than 6 words, and then all of a sudden they're just kind of speaking nonsensical speech and you can't really understand what they're saying. And that can happen, you know, over the course of a few months, and that might be a sign that they're starting to decline. So anything like pain that's uncontrolled, anxiety, shortness of breath, constipation, all of those things are things that we manage. That's kind of our bread and butter. So anybody that has those kinds of symptoms that you may think of, that's who we're happy to evaluate and, you know, put onto hospice services and see if we can get them that extra support in the home. And then we have our FAST scale. So this is one that's specific to Alzheimer's. So it's kind of a progression of Alzheimer's, and it doesn't include like vascular dementia and other types of dementia. It's very specific to Alzheimer's. This is typically the disease process that you see. So we typically look for somebody to be in the 7 range. So if you look at that 7 category, the ability to speak is limited to less than 6 intelligible words in the course of an average day. They're no longer able to walk. They are incontinent of both bowel and bladder. Those are things that are going to trigger us to say that this Alzheimer's patient may be declining and have less than 6 months. So.
And just something to add to this visual, that's something that I use regularly. I'm not a clinician, so to the eye, I'm able to see if somebody has declined. And even if we do have those boxes checked, we're out there doing evaluation, it doesn't really mean that they can be admitted at that time, they're eligible for services. But it gives us a good idea of where their baseline is at now versus where we come again in 2 weeks or in 1 month. We can see a decline over time. And when we're evaluating our patients, we're not going based on what's happening that day. We're going to talk to their doctor, to their family, to you guys if it is a progressive visit that you're making pretty often. We're going to talk to everybody involved in that patient's care plan to see where they were at 6 months ago to now. So we take a full decline over time, not just a snapshot picture in that one moment.
Mm-hmm. So these are the common diagnoses that we use. I kind of already touched on those. This is not a full comprehensive list. There are other diagnoses that we've used. Sometimes we get creative. One that we use is senile degeneration of the brain, which is kind of just a fancy way of saying old age. Somebody that's 100 years old and they've just kind of been declining, not eating as much, but they should definitely have hospice services. So that's kind of a creative way that we can get somebody on service. And then severe protein calorie malnutrition. So a lot of times we want to see weight loss in that person, documented that their appetite is very low or not at all. Albumin levels are really helpful for these patients so we can see, how their albumin levels have tracked over time. So severe protein calorie malnutrition is another one that we use pretty often. Other comorbidities that can contribute to the 6 months or less prognosis, kind of the same thing as the list above, but if somebody is on for COPD, but they also have a history of CHF and AFib and diabetes, all of those things together, maybe the COPD is not exactly just that. That's not what's causing the 6 month prognosis, but the combination of all of those is what's causing that 6 month prognosis. So I think the next slide kind of goes over that a little bit as well. All of these things are symptoms and signs that we look for. So if somebody's had recurrent infections, pneumonia, sepsis, their appetite is low, difficulty swallowing, intractable cough, nausea, vomiting, diarrhea, increased pain that's being, it's hard to manage with their regular pain regimen, a decline in their blood pressure, edema, ascites, effusions, change in level of consciousness, all of those lab results are really helpful. We do use something called a palliative performance scale as well, and that's a percentage. So 100% is somebody who's fully functional. Somebody who is on a 10% scale is somebody that's bedbound, not eating, we're doing mouth care only. Their disease process has progressed really rapidly and they are imminently dying. So we use that scale a lot to determine where somebody is at in their disease process. Somebody with wounds, we get those a lot. Anybody that's been back and forth to the hospital that you guys are taking them back and forth, frequent falls, anything really. We just look for all of these signs and symptoms of decline, and we track them over time and see why does this person have that 6 month prognosis. This is the 4 paths to eligibility. So the old school way of thinking in hospice was we have something called LCD guidelines, local coverage determination criteria. So this is what Medicare looks at to see, does this person qualify for hospice? So it used to be that you had to meet all of these criteria in order to qualify for hospice. So somebody with CHF needed to have an ejection fraction of less than 20%, be short of breath at rest, edema despite the use of diuretics. So they had to meet all of those criteria in order to qualify. Now, Medicare is letting us look at people as a whole and their entire prognosis. So if somebody meets the guidelines to a T, great, they definitely qualify. it gets a little bit tricky, but we really try to take on as many patients as we can and help them with, as much support as we can. So if somebody meets most of the criteria but has a very rapid clinical decline, they just had a fall, like Brittany said, they went to the hospital, they're no longer eating or drinking, and but they may not meet all of those criteria, they're still going to qualify for hospice. And then we do have patients who some of them meet kind of most of the criteria, but it's their comorbidities that really qualify them. Like I said earlier, somebody with Alzheimer's may have ischemic heart disease and diabetes and kidney failure, and all of that together is going to qualify somebody for hospice. So we really look at the whole person, which is really nice in hospice. You get to see everything about them and their families, and their care plans are very specific. So all the care plans that we do for each patient are individualized, and they get to include the family unit as well. We have items that we get to put on there, like assessing for the client and family's coping capabilities. Have they accepted the terminal illness? Our aides get to, for their care plans, we can put in companionship. If they don't want a bath that day, you don't have to get a bath that day, and they just get to sit with them and maybe read them a book or, listen to some music or something with them. So hospice is really unique in that. But, these 4 paths to eligibility, the last path is the physician's clinical judgment. So it really does determine, the physician determines if that person has a 6-month prognosis or not. So it's really up to them to determine if that person can qualify for hospice. So those are the 4 paths, and it's a little bit different than the old school way of thinking of hospice, but this allows us to bring more people on and help them when they weren't able to get help before.
And Eric is absolutely right. Everybody deserves hospice when they're eligible for it. So we really try our best to screen them completely. You have a nurse going out to do an evaluation. If it was a good day versus a bad day, well, let's come out a second time, do a second evaluation. If we're still not sure, our doctors come out to see the patient. If we're still on the fence, we're sending it all the way up to our corporate quality team as well. So there's more than just one pair of eyes looking. It's the entire team's making sure if this person benefits, they're getting that extra support in the home.
So some of the skills in the home that we can do CPAP, BiPAP, trachs, vents, Airvo is a new thing that we do. So we can accept all of those patients. We can do palliative transfusions. I had a patient not too long ago that she is, still ANO times 4. She had a desire to make it to this giant garage sale that she does at the end of the year. So her hemoglobin was low, it was 5. So to get her to the end of the year, we gave her a blood transfusion. So those are kind of the things that we do, and we focus on the goals of care for that specific person. So that was her goal, and we got her to the garage sale, so I know she was very excited about that. We can accept patients on short-term TPN. So we have things called IDT meetings. It's interdisciplinary team meetings. We have them once a week, and we talk about our patients and their care plans, their concerns, any medication changes that need to happen. Our medical directors are present during that meeting, and we get to talk about them. Our chaplains, social workers, everybody's involved. So we really get to do the whole care of the patient during that meeting. So when somebody's on short-term TPN, we would monitor them very closely in our meetings and see, what are their goals, and, is this something that they want to be on longer term? So, we also do complex wound care patients. So if somebody needed a wound vac or something, we've done all kinds of wound care. So we've kind of seen it all. So those are things that we can do in the home. If somebody had cirrhosis, needed a paracentesis, they have lung cancer with malignant mets and pleural effusions, then we could do Pleurex drainage in the home. We have the ability to do that. So those are things that we can do to help keep somebody out of the hospital and keep them at home where they want to be.
So everything that we are talking about is covered by the hospice benefit of the Medicare if they're 65 years or older, or their private insurance. We run all eligibility prior to admitting a patient, because if for some reason they fall outside of our contracts, we will refer them to somebody who they will have 100% coverage with. But everything that we are talking about will be covered by that benefit. So all of our intermittent visits by our nurse, our aide, our chaplain, our social worker, we have massage therapy, we have volunteers. We send out DME for comfort. We send out supplies. We have comfort medications. We cover all of that through the hospice benefit. Kind of went through all of that. Like Erica said, our IDT meets weekly. These are everybody involved in that meeting: doctor, nurse, home health aide, social worker, spiritual support, volunteers, and our bereavement counselor. You see PT, OT, and speech up here as well. Sometimes that is needed while on hospice. If a patient had a change in their condition, God forbid they had a stroke, but they just need to relearn a task, we will bring in a company for short-term PT, OT, speech visits. Or if there was a change in condition, they need a swallow test, we'll also bring in a home health company. If it is becoming a long-term progressive therapy course of treatment, we would have to discharge off hospice, let them complete their treatments, and then bring them back onto care. I know this one is hard to see, but I think it's very important, and I'm happy to send a PDF copy to you guys to have a copy of this. But this is the circle of care for a hospice patient. You can see that the patient's in the center. You have your family, your friends, caregivers. The inner layer is everyone on your IDT, and then the expanded layer is what they do. So it breaks down what falls into the role of a social worker and a chaplain. A lot of families get nervous about having them come into the home. They feel a social worker is more of a resource for them other than the patient, which is true, but also that social worker gets to know that patient as well. They can spend the companion side of hospice care with them, like Erica said, playing music, massage therapy with lotion, aromatherapy. It's really the companion side. With the chaplain, we're not there to push faith. It is there as a resource. A lot of people may not participate in their faith preference, but when you're experiencing end of life, all of that changes very, very fast. So they stay involved in the care. That's why they're a part of our IDT meeting. And also, they do all of the bereavement afterwards. So if they need an on-site visit, with that first anniversary of the death of during the holiday season we're coming up, the first birthday, a graduation, or if they didn't make it to what they wanted to, like that garage sale, that's a hard time for the family. We would come out and support them. The volunteers that we have, most of them are from Washington University, so they're med students. They go through all of our Relias training just like we have to as a hospice representative. So it's just as thorough as what we get. What is the role of the hospice care team? This slide is a little repetitive, but also very important to still know. Managing the patient's managing the patient's pain and symptoms can be, again, anything from anxiety to pacing to rummaging through items. Ability to provide excellent care, expert advice, and instruction 24 hours a day, per day, 7 days a week. So hospice is not in the home 24 hours a day. Our visits are intermittent. Our frequency is based on the care needs, and the time we're in the home is dependent on what they're looking for. The example Erica said earlier, if our aide goes on a scheduled day to help with grooming and bathing, if they're having a bad day, they may not allow us to do that care. That's okay. We'll try to just, I'll ask them if it's okay if we can wash their face or comb their hair or clean their nails. Try to do something involving themselves in their day-to-day so they develop that trust more often that they'll allow us to provide care. We're assisting the patient and the family with emotional, psychosocial, and spiritual aspects of the hospice journey. Each day we're providing continuous education of this hospice care and the philosophy of what we're trying to do. We provide the needed medications when needed. So something that I love about Bristol and what every hospice company should do, in my opinion, is introduce comfort medications when needed, not at the first day of care. We want them to be present, involved in their day-to-day activities, present to have quality conversations, say their hellos, say their goodbyes, and be present with their family. So when morphine and Ativan is needed, then we'll have those conversations. But it's probably not happening day one unless it was an urgent need. Honoring the patient's unique and specific goals of care, supporting the family on how to care for the patient. That's a really big one. A lot of families get very nervous when mom goes out to the hospital and she comes back and her care is completely different. That's where our social workers come in as well. We're not enough. We're going to bring in private duty care. We work with several excellent companies in the area and we'll refer out to them if they need that support. Delivery of the special services, so that PT, OT, and speech, and we are there to determine the right level of care. Okay. And add anything if I miss it, but hospice levels of care. So there are 4 different levels. Typically, a traditional hospice patient is on routine hospice care. That is our intermittent visits. That is routine pain, symptom management. It is wherever they call home in that setting. That's what all of our patients are on right now. In the event we start to see a change in condition, we're thinking they're going to be passing soon, then we will change them to what we call daily visits, to where the nurse is going out each day to make sure that that family is breathing appropriately, making sure that patient's not in any pain, making sure their symptoms are managed, and they have the education to get through this patient passing. General inpatient care is GIP. In the event we cannot manage those symptoms in the home and we need a higher level of care, we may move them to a hospital setting and do hospice in the hospital or a skilled facility. Continuous care is when we're in a crisis mode. The symptoms need a lot more intensive management, but still can be managed in the home. Continuous care puts a nurse in the home at minimum of 8 hours, correct? Minimum of 8 hours in a row, okay? And then we may have to step out. If we need to come back later, then we will, but we stay there until those symptoms are managed. And respite care. Caregiver burnout is a real thing. So in the event somebody is on hospice, but the caregiver is struggling, she's not sleeping, she's not eating, we gotta take care of ourselves to take care of our loved ones. Or if there's just a planned vacation and you're going because you need to take care of yourself, respite care is available to where we would put your loved one in a home for 5 days, 4 nights covered by your Medicare benefit. It does need to be a skilled facility. We do need to be contracted with them. If we are not already, we would just get a contract. It's quite simple. Okay. Also a little repetitive, but very similar to the screening tool. Indicators that a hospice conversation is necessary. Are we seeing an advancement in that disease? Are we seeing an increase of frequent infections? Are we going back and forth to the hospital? Are we seeing a lot more weakness related to falls with or without injury? Significant decrease in appetite, multiple needs, weakness in daily activities, swelling in the legs or ankles, increased confusion, sleeping more than being awake. But also take a step back and look at their environments. Like Erica said, are they not taking care of the day-to-day like they normally were? Are you coming into the home and somebody's not bathing or showering as often as they used to? Is their garbage still out on the sidewalk days in a row? Is their yard not cut? Is their mailbox full? We're looking at all of those things that you would see as we're walking into the home. That may indicate that they need a little bit more support, whether it's hospice or not. And what makes us a little bit different. So not every hospice company has this. This is what we have to offer. A Bright Moments program. I have a small brochure in the back, but it's more of a therapeutic, holistic approach to challenging behaviors. So as a hospice company, our goal is to making sure that they are involved in their day-to-day, having the best quality time that they have left. So we implemented a program that gives us something to do with our residents, give the family something to do with their loved ones when we're not there. So the Bright Moments program gives the patient a weighted blanket, aromatherapy, massage therapy, a companion bear, a nosy cup, a maroon spoon, almost everything to help heighten the senses when we're looking at challenging behaviors. So all these items prove to show a decrease in behaviors when we're distracting them or whatever's happening in the head. You need to give them something to do. Sweet Dreams is not implemented yet. It's a different program, but it's all about a bedtime ritual where we would come in and help put that individual to bed. Perfect Harmony is something we do in our facilities to ensure there's collaboration between the hospice company, the family, as well as the staff in the building. It also ensures that they're always stayed ready because they can walk in the building any minutes. High frequency aid, if we do have home patients, we are able to put an aide in the home 5 days a week, Monday through Friday, to help with the bathing and the grooming. That's really if their care plan determines it though. Rapid response time, anytime you call Bristol Hospice, a representative is there within the hour, and a phone call is definitely made within 30 minutes. The Bristol Promise is just going over kind of what we're able to do in the home, so back to those skill sets with the air bow and the vents. Our goal is to make sure that any plan of care, any goals of care that they have created for themselves, we are going to try our very best to make sure that happens. And Bristol AIM is Advanced Illness Management, is not in play in St. Louis just yet, but it would be palliative care.